Hello. The three issues with this patient today are heparin-induced thrombocytopenia with thrombosis, urinary tract infection, and supportive care measures that are important in chronic kidney disease, including anemia and hypophosphatemia. So the first problem we're going to talk about is the heparin-induced thrombocytopenia with thrombosis. This is evident by the fact that on admission, platelets were 196, and today on day 7 of treatment with heparin, platelets have gone down to 47. In addition, he has skin necrosis on his left upper extremity, as well as potential acute systemic reaction, which includes fever, chills, tachycardia, hypertension, and dyspnea. As well, his ELISA test is positive for the antibodies, and we're suspecting that the pulmonary embolism has not resolved based on recurrent hypoxia. So his 4T score is a score of 8, which indicates a high probability of this being heparin-induced thrombocytopenia. And for that reason, based on the CHEST guidelines, we'd like to discontinue heparin immediately. We would also like to start new anticoagulation immediately, which will be argatroban 200 micrograms per minute as a continuous infusion. We're going to adjust this dose in order to maintain the APTT levels at 1.5 to 3 times the baseline. We're going to make this dose adjustment every 2 hours. The maximum rate of infusion is 1,000 micrograms per minute. We're going to continue this until platelets are greater than 150, and we're going to continue it. And once the platelets reach 150, we're going to start the warfarin, and we must continue the argatroban for first 5 days of being on warfarin therapy. So with the argatroban therapy, we're going to monitor APTT every 2 hours, CBC daily, electrolytes daily, blood pressure and heart rate every 2 hours, and signs of bleeding continuously as this risk is increased with the use of argatroban. As I said earlier, we're going to start the warfarin therapy once platelets have reached 150. So we're going to start warfarin 5 milligrams PO once daily. I want to reiterate the fact that we must continue the argatroban for a total of 5 days after starting the warfarin therapy, and once we've obtained 2 consecutive INR readings between 2 and 3. So we're going to continue this warfarin therapy for a minimum of 3 months, and then we can reevaluate the need after this 3-month period. Again, all of these recommendations are based on the CHEST guidelines. We're going to monitor the INR daily during the bridging therapy with argatroban, and then every 2 weeks upon discharge until we've stabilized the dose. So the second problem we're going to talk about today is urinary tract infection. This is evident to us by the microbiological urine sample, which showed greater than 100,000 gram-negative rods. In addition, he has a white blood cell count of 19.5 and a fever of 38.2 degrees Celsius. So based on the IDSA guidelines for treatment of complicated urinary tract infection in males, we would like to initiate levofloxacin 750 milligrams by mouth every 48 hours for a total of 10 days. Like I said, this is based on the IDSA guidelines, and the frequency is based on his creatinine clearance of 38.92. We're going to monitor the white blood cell and fever daily, and because he's a male, we'd like to obtain a urine culture within 4 weeks to ensure that this infection has been cleared. The final discussion we're going to talk about today is chronic kidney disease and the supportive care measures that are important to maintain while inpatient. So based on the KDIGO guidelines, patients with chronic kidney disease are classified as having anemia when hemoglobin is less than 30. Today, this patient's hemoglobin is 12.9, therefore iron therapy is warranted. We're going to initiate ferrous sulfate, 1 tablet by mouth 3 times a day for a total of 1 month. It is important to administer this medication 2 hours after the levofloxacin antibiotic that we're using for the urinary tract infection due to a potential drug interaction. We'd like to obtain the TSAT and ferritin levels after this 1 month of treatment to decide if continued therapy with iron is warranted. We'd also like to monitor the CBC daily while inpatient to ensure that the hemoglobin levels begin to rise. The other abnormality that requires supportive care measures in this patient is he has a low phosphate level. Today it was measured at 2.3. So for that reason, we'd like to administer 15 millimoles of potassium phosphate intravenously over 4 hours with a max rate of 10 millimoles per hour. For the monitoring parameters with this, we'd like to obtain electrolytes daily to ensure that the phosphate levels are returning to normal. Thank you for your time. What questions do you have?